Okay, our next and final presentation before lunch, CTNNB1-related movement disorders, a complex but recognizable phenomenology. Dr. Garone Giacomo, neurolog, Epilepsy and Movement Disorders Unit, Bambino Gesù Children's Hospital in Rome, Italy.
Thank you very much. I hope you can see my screen and hear me.
Yes,
I'm very happy to participate and honored, and thank you very much for this kind invitation. And I will talk today about movement disorder phenotype in CTNNB1 syndrome. As you all know, motor disorders are a core feature of this condition. From the very first reports, progressive lower limbs hypertonia has been described, leading to include spastic diplegia among the core symptoms of CTNNB1 syndrome. But later, many other movement disorders have been described, including dystonia, described as dopa-responsive in some reports, chorea, tremor, ataxia, and as you heard before in other presentation, exaggerated startle.
Giacomo, I'm sorry to interrupt. Would you please change your settings to presentation mode? We see all your slides at the bottom, and it'll make them bigger for us. Thank you. Sorry for interrupting.
Now it's okay?
No, we don't see your slides now at all. That's better. Thank you.
Now?
Great. Yes.
And as you and also peripheral neuropathy has been described as a cause of motor disability in these patients. And so the phenotype appears to be very, very broad and heterogeneous. So to better understand and define this issue in CTNNB1 syndrome, we decided to systematically investigate these aspects in patients referred to our hospital. And we systematically assessed the cohort of 14 patients with CTNNB1 syndrome to better characterize their motor phenotype. And all patients were so enrolled and studied at Bambino Gesù Children's Hospital in Rome. As you can see, all of them were carrying lots of function variants of CTNNB1, mainly truncating and nonsense variants, but also a large intragenic deletion. First symptoms were, according with previous reports about this condition, were congenital microcephaly or developmental delay. And but in 13 out of 14 patients, walking acquisition was characterized by some abnormality in gait pattern, in most of the patient by broad-based gait or other or tip 2 gait. And in most of the patients from the age of 4, progressive lower limbs hypertonia was noted. Cognitive and behavioral abnormalities were also common. All patients were found to have intellectual disability, and most of the patients were showing some behavioral issues. And with regards to to motor phenotype. Before diagnosis of CTNNB1 syndrome, the motor phenotype had been variably described as spastic paraplegia in most of the patients, or less commonly as a spastic ataxia, as a isolated ataxia, or focal dystonia, focal lower limb dystonia. But at our evaluation, the phenotype was not so heterogeneous as it was supposed to be. Most of the patients were showing a broad-based gait, and one patient was showing an intuiting gait, and one patient was showing an unilateral foot eversion. One other patient was showing a tiptoe walking, and one patient did not show any overt motor abnormalities and had a normal gait. Assessing tone of our patients, we found that pyramidal signs, overt pyramidal signs were not common. Babinski sign was not found, ankle clonus was not found, and also velocity-dependent hypertonia and spastic catch were not commonly found. Two patients were found to show cogwheel rigidity. Only brisk reflexes were common. And we found a striatal 2 in 7 of our patients. However, lower limb hypertonia was very common and it was found in all but one patient. I will show some example of the gait. As you can see, gait is characterized by this broad-based pattern. That is very, very, very typical and common across the patients. Sometimes intuiting can be seen. And in the other video, you can see the striatal 2, meaning the upward deviation of the big two in absence of planning of other twos to plantar stimulus. That is considered an extrapyramidal dystonic sign. Other movement disorders have been encountered in our cohort. Upper body dystonia was found in 3 patients, mainly involving the craniocervical region and the upper limbs. You can see in this video, also can be difficult because of the blurring, but you can see the dystonia of the head and neck. And also bradykinesia was also found in 2 patients. So slowness of movement and reduced amplitude. And these symptoms were encountered in adolescents and were reported to be noticed from the age of 10. So it seems to be something that is more common to occur in the second decade of life. You can see the progressive reduction in amplitude and speed of the movements. And as it was mentioned before, the exaggerated startle is a common complaint, and as you can see from the polymyographic recording, this is actually an exaggerated startle reflex, and this is not other type of reflex myoclonus, but it's a true case of exaggerated startle reflex. We revised the diagnostic investigations performed in our cohort, and we found that one patient underwent that scan that was normal, so there was no evidence of nigrostriatal degeneration, and MRI was normal except for unspecific findings in most of the patients. We found two cases of unspecific and not clearly related with CTNNB1 syndrome findings, such as a left caudate nucleus specification and white matter hyperintensity in the supratemporal white matters. Spine MRI was normal in the 4 patients who underwent this exam. And neurophysiological investigations were normal in 4 patients that were investigated through these methods, both nerve conduction studies and motor evoked potentials. With regards to treatment, 4 patients were treated with a trial of levodopa, but only one found some benefits. On motor slowness, mostly. And the other patient did not find significant benefit. And botulinum toxin was used in 6 patients with some benefits in 5. And trihexyphenidyl and biperidan, so anticholinergic medications were used in 2 patients with some benefit in 1 to treating dystonia. Excessive startle was treated with carbamazepine, clonazepam, and hydroxytryptophan in 1 patient with no benefit. And orthopedic surgery was performed for secondary skeletal deformities in 2 patients from our cohort. So our conclusion about a detailed revision of the movement disorder phenotype in CTNNB1 syndrome are that this condition is characterized by a complex but a highly recognizable movement disorder phenotype. This is an important message for pediatric neurologists, in my opinion. Despite a heterogeneous description in the literature, the phenotype is quite homogeneous. The main abnormality, as you all know, is the progressive lower limb cell hypertonia that causes significant disability. But this hypertonia lacks in most of the patients overt pyramidal signs and probably underlies a prominent rigid, maybe dystonic component that is not really highlighted in the literature. In the second decade, there is the possible occurrence of upper body dystonia that should be investigated and treated accordingly with disability. Exaggerated startle is a common complaint that should be addressed in every CTNNB1 patients. And despite some previous reports, we did not find a good response to levodopa in the few patients we treated with it. So botulinum toxin seems to be more effective, at least to treat lower limb hypertonia and the disorders. at least in patients that have at least in patients who do not show osteoskeletal deformities. And we propose to avoid the term peripheral spasticity that is commonly used in describing this condition, because it's quite confusing about the true definition of the disorder of tone in these patients, and we suggest that other investigations about the most effective treatment for lower limb hypertonia should be carried out. The next steps at our center are to keep investigating these aspects in CTNNB1 condition through longitudinal kinematic assessment and MRI assessment, and by deeper neurophysiological investigation. I just want to conclude to say thank to my colleagues in Rome and in Italy who support this effort to care and study of this condition. And I want to thank the organizer and all the participants for your attention and for your invitation. Thank you.